So we've now got over 100 people in the room. So I'm just going to kick off and welcome everybody. So thank you so much. This is an amazing turnout, and I think it just shows how much interest there is in what you're going to hear today on inequalities, on the impact of COVID, particularly on BAME communities, and how that might have a meaning for us in the sort of HIV sector and what we might do. So just to introduce myself before I introduce Kevin. So I'm Gemma Gilbert. I'm a Director of Transformation at Healthy London Partnership, and I'm your host today, which basically means I'm going to be doing a lot of the housekeeping. So as people have been joining, I've been mentioning that we're recording this session, and it will go on our website because I think people who couldn't join today will very much want to hear what Kevin has to say. But what that means is if people could, throughout the course of the session, turn the cameras off. I want to see all your lovely faces, but turn the cameras off and stay on mute, and you'll get the best sort of listening experience, and it will eliminate any background noise when Kevin presents. We'll have a Q&A later on, and you'll be able to come back on. And what I'd like to do is encourage people to use the chat box. So if you have access to the chat box on your system, then you'll be able to leave some questions or messages there. When we come to the Q&A, I'll be able to sort of group some of those together for Kevin to answer. And if we have time, invite you on screen to put that question to him. But without any further ado, I'll just introduce Kevin and today. And as you all kind of, I hope, know, we've got 125 people now. The Fast Track Cities network that we have for tackling HIV is very much designed to be owned by the wider HIV community and provides a real platform for coming together, for learning together, and for sharing our joint aspiration and goals around getting to zero in London. So it's an absolute honour to be able to host that on behalf of the network for you all today. And Kevin, who is our Regional Director for Public Health England for the whole of London, who's led on the national report into looking into the kind of inequalities of COVID, is I'm sure going to have some really interesting insights to share with us. I've seen the slides and it looks really good. So Kevin, do you want to see if you can come on screen? I don't know if you've got your camera on.
Yes, the camera is on, and can you hear and see me now?
Okay. I can see, yes. Hello, Kevin. It's lovely to see you. So, so if you're happy, we'll bring the slides up and give you some time to run through those. And then, as I say, people will hopefully be leaving some suggestions and comments in the chat box. If you can see it, or if you can't see it, let me know, and we'll keep an eye on that for you. But welcome to the presentation. I'll hand over to you now, Kevin. Thank you.
Great. Thank you very much, Gemma, and good afternoon, everyone. It really is a pleasure to be here with you this afternoon. And when I discussed the idea of doing this with Gemma and Jess and Jane Anderson, Professor Jane Anderson, we thought it was really important that the engagement that we were able to do with so many of you as we were doing this work on COVID and its impact on Black, Asian, and minority ethnic groups. It was important for us to circle back to you as stakeholders to share both the findings of the work that we did in Public Health England, because so much of it cuts across our experiences with HIV. But secondly, to begin thinking about the implications of living with COVID, which we are likely to be doing for many months, if not years to come, until an effective vaccine is available, and what that might mean for HIV prevention and our HIV programs. Now, as I start the presentation today, I want to begin by just, first of all, acknowledging all of you for the really tremendous work that you've been doing over the past 6 months. Many of you have been directly affected by COVID. You may have had friends or family members, or you yourself have been affected by COVID. And it has been a difficult time for all of us as Londoners, colleagues across the country, as we've gone through this first phase of the pandemic. On the plus side, there's been a lot of innovation, lots of new ways of working, lots of new ways of tackling very old problems that I think we can certainly build upon. But as you'll see in the presentation today, COVID has also shone a light on inequalities. And in many areas, COVID has made them worse. So as we emerge from this first phase of the pandemic, another reason to share these data with you today is for us to be absolutely clear that our experience in the HIV prevention and the HIV treatment and care family of understanding inequalities, of controlling a pandemic, of working with communities, of using data, of getting the best surveillance are exactly the things that we need to get beyond COVID. So I'm hoping that as we have the discussions later on, that your ideas on what more we can do to tackle this epidemic, especially on its impact on BME communities, I'd love to hear your thoughts as well. So next slide, please. I'll run through these slides. The presentation is designed in 4 key sections. In the first section, I'll do a brief overview of the pandemic and where we are. In the second section, I'll be discussing the 2 reports from Public Health England. And then finally, I'll end with a little bit of reflection on HIV and the intersection with COVID, what it means for work, as well as the recommendations from this work. So this first slide is just really to acknowledge the journey that we have been on over the past 6 months. It's very, very hard to believe that the first case was actually reported in December of 2019. And in 6 to 7 months later, we have more than 188 countries reporting the infection, with more than 10 million confirmed cases and more than 500,000 deaths. And for many of us, this is the first time we're going through this type of experience. And for all of us, it's the first time we're experiencing a pandemic of this nature and severity. So the next slide just highlights some of the key findings of what we now know about COVID. When we started this journey, assumptions were made about it being probably a flu-like illness. And so many of our assumptions or initial approaches to COVID were certainly based upon a lot of flu planning which had taken place. But now we know that person-to-person transmission is an important route of transmission, largely by respiratory droplets. There is now increasing evidence to suggest that aerosol transmission will be or can be an important part of the transmission of COVID, so that particles may remain in the air over time and in distance. Clearly, we know about infected surfaces, and the virus itself is expressed in a number of body fluids and excretions, including stool, blood, semen, and ocular secretions. Yesterday in the press, there was the first report of a cat that was infected with COVID, but with no known links to any human transmission, and that's really important. But as we learn more about the infection, we will learn more about opportunities for intervention and control. The next slide also speaks about some of the clinical features of COVID that we now know and understand. And perhaps most importantly is the fact that underlying medical conditions are strongly associated with an increased risk for severe COVID disease. And prior to the work that we were doing on the impact on BME communities, there were signals from the Far East, from Europe, about conditions such as chronic kidney disease, chronic respiratory disease, being immunocompromised from organ transplantation, being obese, especially with a BMI over 30, as well as cardiometabolic diseases and conditions such as sickle cell disease and type 2 diabetes. And these conditions are important because certainly in our society, many of these conditions are very strongly socially and economically patterned. In other words, they have higher prevalence in more deprived parts of our communities. And many of these conditions are also more prevalent among Black, Asian, and minority ethnic communities, which may in part be reflecting either genetic predisposition to these conditions or poverty, deprivation, poor access to services. So the signals of perhaps a disproportionate burden on BME communities might also take its root in the fact that there are medical conditions which are strongly associated with the risk of severe COVID disease and death. And then the final sort of introductory slide on COVID, which I really wanted to highlight here, is that as the epidemic spread from the Far East across Europe to the United Kingdom and the US, we began to see very early signals of its severe and disproportionate impact on different parts of the community. So here I show some of the data, for example, from the United States, looking at age-adjusted COVID hospitalization rates by race and ethnicity, and showing the significant differences between minorities within the US and white non-Hispanic populations. And for many of you who are aware of the US healthcare delivery system, you may well say, well, this really reflects the type of healthcare system that we have in the US, historic aspects of poor access to services, and inequalities in quality of services provided to minorities. But I think the consistency of the data, where we have significant minority populations, whether in Western European countries, whether here in the United Kingdom, or in the US and Canada, we do see this disproportionate burden of disease. And again, it was because of these findings of multiple long-term conditions, of emerging disparities, that Public Health England was asked in April, initially by the CMO and then commissioned by the Secretary of State, to look at disparities in risks and outcomes for COVID, with a specific focus on understanding COVID's impact on Black, Asian, and minority ethnic communities. So the next slide, please. So at this point, what I'd like to do is to move forward to discuss the different the next one that were produced. I'm not sure if the slides are stuck. But
Palia, can you move the next slide? Unfortunately, I've not got control, Kevin.
So I have them. Is it not moving? It has. Okay. It might be.
You could always come back out and back in again, Palia. That sometimes unblocks it.
Has that helped?
Right, excellent, it has, yes. And so as we go into this next section of the presentation, I just wanted to pull out what I think is a really nice similarity and a way of beginning to think about not only the impact of COVID in terms of its impact on minority communities, deprived communities, the differences by sex, by occupation, but also as we think about how we prevent and create resilience for communities, HIV's experience with combination prevention really comes to the fore. And here I've highlighted some of the key interventions which we now know are effective in helping to both reduce risk of acquisition of COVID, but also to reduce severity of disease and death. So these range from social distancing, hand hygiene practices, the use of masks, the evidence of which now is far more robust than it was 6 months ago at the beginning of the pandemic, ensuring that there's good access to environmental cleaning and ventilation, and of course, the importance of reinforcing testing and isolation, screening, the use of PPE and and lockdowns in event of hyperendemic levels of disease. So we have learned a lot, I think, in these last 6 months. And it's really important that we now bring this learning as we think about the impact on disparities, on different communities, and we prepare for the next phase of the pandemic. So the next slide. So what I'd like to do now in the second part of the talk is to reflect on the reports from PHE. So there were 2 reports which were commissioned by the Secretary of State for Health. The first was delivered at the beginning of June, and this focused on the disparities in risks and outcomes of COVID. And the second was an extensive stakeholder engagement review of the literature with BAME communities to understand the context which are driving the patterns of disease among Black and minority ethnic communities. So this slide just gives you an idea of what we've been through in the first phase of the pandemic. I'm really pleased to say now that levels of disease are now low in most parts of the country, although we know that there are areas which are still struggling to get levels of disease down, such as Leicester, Bradford, other parts in the Midlands and the northwest of the country. But overall, the pattern certainly has been positive in terms of declining incidence. And certainly London, which had been hit early and hit hard by COVID, certainly is seeing now some of the lowest numbers of infections per day within the city. So each day in London, we see between 70 and 80 new infections. And of course, deaths within the city have declined significantly as well. So the next slide just illustrates the first report and the key objectives of the first report. We were asked to look at the surveillance and epidemiological data held by Public Health England and our partners to understand disparities in the risks and outcomes from COVID-19. We were going to use our surveillance data and the data to the time of publication, as well as linking to a number of broader health data sets which were available at that time. And what we wanted to do was to confirm the impact of COVID on inequalities which were pre-existing and to understand where those disparities worsened over the past few months as a result of the epidemic. And the results of this part of the work would certainly inform both future research as well as further work in this field. So essentially in the epidemiological review, we looked at three key areas. We wanted to look at disparities in testing for COVID and to understand whether there were differential aspects of the likelihood of being diagnosed with COVID across a range of characteristics, including age, sex, where in the country you live, your occupation, your race and ethnicity. We were looking also in the epidemiological review in the severity of the disease and the factors which influence the severity of disease, as well as factors leading to mortality from COVID. So the next slides are really just highlighting a number of key disparities which we saw, which is really important to put in context. In other words, although we saw differences across racial and ethnic groups, we also saw stark disparities in other groups as well. So in this first slide, we look at disparities by age and sex, and we see the significant burden of disease of diagnosis rates, certainly in those aged over 70 years, and especially those 80 years and over. For those aged over 60, we saw more male diagnoses than female diagnoses. And for those aged younger than 60, we had a preponderance of females being diagnosed with COVID. But the clear pattern that we see here is the older you are, the higher the likelihood of being diagnosed with COVID at that first phase of the pandemic. The next slide looks at another domain of inequalities, and this is by geographic area of residence. And as I said, London was really severely hit by the epidemic, and you can see this by the very dark shading of the rates of diagnoses by local authority and sex for both men and for women. We see here, with a number of boroughs in London having that dark shade. And you can see across the country significant variations in the rates of disease and the concentration, especially in metropolitan areas, of higher rates of infection compared to the more rural parts and more rural regions of the country. And the only distinction here is that we saw the very high diagnosis rates in women, in females in the northwest of England and in the north compared to men. And this may well reflect patterns of occupational exposure, especially to women in the caring professions in the north and northwest in the country compared to other parts of the country. And at the next slide, a key feature of the disparity that we observed was the very strong association between your likelihood of being diagnosed with COVID and deprivation. And for those individuals living in the most deprived parts of the country, they were between 1.7 to 1.9 times more likely to be diagnosed with COVID compared to those in the least deprived parts in the country, with that difference being more marked for men than it was for women. But you can see here a very clear pattern of differences in the likelihood of diagnosis of COVID by levels of deprivation. So more deprived areas seeing higher diagnosis rates. And then the next slide illustrates the patterns of disparities that we observed across the racial and ethnic groups. And again, we see here with higher rates of diagnoses among those in the other ethnic group, Black ethnic group, and Asian ethnic groups, with the lowest rates being seen among white ethnic groups. Now, clearly, the very stark diagnosis rates in the other ethnic groups are likely to be an overestimate because of how individuals completed or the data were captured related to ethnicity of individuals and how those data were actually coded. And so we need to do more work here on this to really understand the impact of COVID on ethnicity. And this is why one of the key recommendations arising from this work related to better data and better information for the understanding the epidemic. So these illustrate some of the differences that we saw in diagnosis rates. And again, very marked differences by age, marked differences by deprivation and by sex, and also disparities by ethnicity. In the next slide, we begin to now look at the epidemiological data that looked at death and the factors which influence death rates. The next slide looks at another domain of inequalities in mortality, and this is mortality by deprivation. And as we had discussed before, you were more likely to be diagnosed with COVID if you were living in a deprived part of the country. We also saw that the mortality rates from COVID in the most deprived parts of the country were more than double the least deprived parts of the nation for both men and women. So the impact of deprivation is significant, and we saw that for both genders. Finally, we also looked at mortality, next slide, by ethnic group. And this is where we began to see some very interesting patterns occurring in terms of the nature of disparities across racial and ethnic groups. So there are three key findings here. I'm not sure if the slide is not advancing again, but if you could try, that would be great. The first is that for nearly all minority ethnic groups in the country, they recorded higher levels of mortality than white British individuals. And this was a consistent finding throughout the course of the epidemic. Second, that within the BAME group, there were significant variations across the racial and ethnic groups, with British Bangladeshis having some of the highest rates of disease and likelihood of death from the disease compared with other ethnic groups. But for the other ethnic groups, the risk of disease varied between 10 to 40% increased risk of death compared to the white British group. The next slide is slide 18, would be the slide that we need to go to. Thank you very much, to show the data on mortality rates by ethnicity. And again, just confirming on the right-hand side of that chart, the bars which really show after an adjusting for the effects of sex, age, deprivation, and region of residence, you could see that these differences in mortality persisted, with British Bangladeshis having the highest risk of death compared to other ethnic groups. So this is a really important finding in terms of confirming this differential mortality by ethnicity, and that even when you took into consideration sex, age, deprivation, and region of residence, you still saw this difference. But what we weren't able to adjust for in this epidemiological study were factors such as the social and cultural factors which may be driving these differences. So whether it is living in an overcrowded home, living in a multi-generational family, looking at a particular occupation, or controlling for multiple long-term conditions. We were not able to do that in this analysis, and that may well explain some of the residual differences that we see here in this chart. So the next slide then, slide 19, please, just really summarizes what we see in terms of the risk of death and survival with the disease. The risk of dying following a positive COVID test was 70 times higher in people who were 80 years compared to those who were 40, higher in men than in women, higher in those living in more deprived parts of the country, and higher among BME groups than the white. And again, this was after
come out of this first.
Sorry, Karen. Apologies. Nuala, could you put yourself on mute? Everyone can hear the background noise. Thank you so much. Thank you.
Brilliant, thank you, Gemma. And so this is just to summarize what we understood about mortality from the disease. And the next slide highlights, please. Thank you. That again, the review really confirmed the disparities which exist both through geography and through deprivation, and the differences by sex as well. So some really stark inequalities which have been uncovered by COVID. Next slide. And again, this slide just summarizes the data on differences by ethnic group and sex relative to the white population in England and Wales. And again, what we're beginning to see was that the PHE data really confirmed other sources of information that were beginning to emerge from the ONS, for example. And these charts are taken from ONS data, which really show the differences in terms of the rates of death by ethnic groups. But we also saw from other studies which were being done, for example, in critical care units, about the higher likelihood of admission to clinical care units for people who were South Asian or Black ethnic groups. And that's, again, even after you take into consideration age, sex, deprivation, and comorbidities. And many other studies have now confirmed that the risk of death is higher among BME groups than among the white British group. And again, after adjusting for a range of factors. So the next slide then moves us on to the second report, which I'll go through quickly so we'll have time for questions and discussion. And the second report really provided context. It helped us to understand not only what was happening epidemiologically with COVID and its impact on different groups, but began to unpack the why. And we did this by doing a number of things. First, we did a rapid review of the literature to understand what was being observed both in Britain as well as other Western industrialized countries in terms of differential patterns of the impact of COVID on BME groups. And we also engaged with stakeholders. And I know many of you on the call were able to join one or many of the sessions that we held. And over the 6-week period that we did this work, between the commissioning in April and the report being submitted at the end of May, we engaged with more than 4,000 people from a range of backgrounds. And they are highlighted there on the slide. People from the devolved nations, the voluntary sector, faith communities, all layers of government, all layers of health, both mental and physical health, academia, and think tanks. And the objectives of the exercise were highlighted here to really clarify what we were doing in terms of the ask from the Secretary of State, to really begin to go beyond the data to understand what was happening with various communities, and of course to identify opportunities for action. So the next slide highlights and summarizes some of the findings from the literature review. Very important that even at that point in time, and this was done in collaboration with the NIHR, the data were beginning to indicate that BME groups were more likely to be tested for COVID and more likely to test positive with the disease. They were at increased risk of death associated with COVID, and that ethnicity and income inequality were independently associated with the risk of dying from the disease. The literature review also showed us some of the factors in social and the cultural context which could be driving these differences in BME communities. The fact that many live in overcrowded housing or in multi-generational households. the fact that many BME individuals worked in occupations that placed them at increased risk of exposure to COVID-19. And that was whether caring for somebody who may have been infected with COVID, for example, nursing assistant, care home worker, a porter, or somebody who was in contact with high numbers, a high proportion of members of the population. So for example, security guards, bus drivers, people working in the transportation sector. The literature review also confirmed that individuals from BME group were less likely to seek care when needed, in part because of their own experiences of using healthcare systems previously. So there was reticence about accessing care early. And there were also signs from the literature about BME groups being less likely to speak up when they had concerns about risk, PPE availability, or testing. So the literature review really began to unpack some of the reasons why we may be seeing some of the differences across racial and ethnic groups. But what did we find from our stakeholders when we engaged with nearly 4,000 people? And what were some of the key themes that came out of those stakeholder interviews? Well, as you can imagine, I won't be able to summarize that in many slides, but the next slide is really a slide which illustrates the main themes from the report, as well as the sub-themes. And if you haven't read the report, I would really encourage you to read them, because they tell both a powerful story of trauma that many communities have experienced going through this first phase of the pandemic, a powerful story of loss, a powerful story of, in many cases, being left behind, whether not getting the information they needed or in the formats that they needed, and therefore leading to significant confusion and the sense of not really being able to protect themselves from and their communities from the epidemic. But there is also a story of resilience and a story of making sure that this never happens again. And the stakeholders who were interviewed were very clear about key recommendations and asks of government, of wider society, to help to mitigate the impact of COVID on their communities. So in the interest of time, I'm just going to introduce the 5 key themes that arose from the work. The first related to factors which created long-standing social and economic inequalities. The second related to factors which increase the risk of exposure to COVID. The third increased the risk of complications and death from COVID. And again, a lot of rich qualitative data here that helps us to understand what was going on, especially within the hospital setting. And then fourthly, a significant part of our conversations with stakeholders related to the impact of racism and discrimination and structural factors, and how that disadvantages communities' choices and their abilities to be engaged in protecting themselves and taking up preventive interventions moving forward. So the next slide just highlights some of these findings in a bit more detail. I'll go through them quickly so that we can, to give you a feel of some of the rich qualitative data that arose. And then I'll pause to reflect for what this means for HIV prevention. So number one, main theme about long-standing inequalities. So many BME communities actually entered the pandemic being far behind. 10 years of austerity, 10 years of a significant structural and economic disadvantage that communities experienced prior to COVID meant that they were coming into the epidemic at a disadvantage. And so as some said, the deprivation, which was a driver for both diagnosis and death, was not new. It's an ongoing issue for many communities, but certainly the epidemic has made it worse. Second, themes related to increasing risk of exposure to and acquisition of COVID. We had lots of discussion here about key workers and risks to key workers, the higher use of public transportation, again, multiple occupancy households, and the issues here about access to and uptake of PPE, risk assessments, etc. So again, we saw in terms of some of the comments that BME workers were significantly more likely to be reliant on public transportation, and that more should be done to recognize and safeguard and protect frontline workers. We must take greater care of those who take care of us and our loved ones. A really powerful statement about the role of key workers and how we value key workers in our society. The third area was around complications and death from COVID. And again, high rates of multiple long-term condition, poor mental health, poorer uptake of preventive services, and the importance of risk factors such as diabetes, obesity, and cardiovascular disease were all seen to be both more prevalent in BME communities and therefore place them at risk of higher risk of severity and death from the disease. Next slide shows the fourth key theme that arose from the work. Next slide, please. And this is around racism, discrimination, stigma, fear, and trust. And again, this may have influenced late presentation for treatment. It may have influenced people's sense of agency to ask for and to access PPE. Issues related to occupational risk assessment were important here, but also important was the role of faith and culture and trust, and how the pillars within many communities were perhaps in the first phase of the pandemic not fully engaged, and moving forward, we needed to ensure a community-driven, a community-led response to help to mitigate the impact of COVID on these communities. And this then relates to how we stakeholders felt that we should be moving forward, of the importance of acting now, of cross-government action, sustainable change, communications, better communications, which are culturally specific, and of course, improving the research that was done. So a number of key themes that are coming out of our stakeholder engagement. And this then led to the next slide, which were the key recommendations from the report. We won't have time to go through these in any great detail, but just to say there are only 7 recommendations arising from this work, and we were deliberate in having 7 recommendations for 3 reasons. Number 1, we wanted recommendations which were achievable, acceptable, implementable, scalable, and appropriate, so that between the end of this first phase and the potential for a second wave, we could hand on heart say we have made progress in implementing these 7 recommendations. Number 2, we wanted to ensure that the recommendations were not focused on things that were necessarily in the long term. Yes, we have to address racism. Yes, we have to address structural disadvantage and economic disadvantage. But as we think about what needs to be done, especially in this initial phase, between waves of the epidemic, we really wanted to focus our hearts and minds and organizations on things that could be done. And then thirdly, the recommendations cover better data collection, better accountability for action on inequalities. It talks about cultural competency, both in terms of health promotion and the delivery of services. And it also speaks to the recovery process, that as we recover health services, we restart our community services, and we rebuild our society, that we do this through an equity lens. Because over the past 6 months, communities have fallen much further behind. So going back to where we were in January will only worsen inequalities rather than help to address them. So equity and addressing equity has to be at the forefront of everything we do. Finally, just want to end then by just reflecting on what this means for HIV and HIV prevention. Many of you are living this, and I look forward to hearing your comments, and certainly in the chat, seeing the comments that you have related to this. Next slide, please. The first is just to ensure, and the next slide, that we know that there has been a significant impact, next slide, on obstacles to treatment access. I'm sorry, you skipped one. If you could go back one, please. Thank you, that's it. So 3 key areas in terms of the impact of COVID on HIV. Have there been obstacles to treatment access and HIV prevention access? Yes, we know that during the lockdown period, people continue to meet each other, have sex, that transmission risks were there and may have occurred. The need for ongoing support for people as we emerge from lockdown, as we re-emerge in society, will be important. Clearly, if we believe that HIV transmission and HIV prevention is related to social and economic and structural disadvantage, then all of these have been worsened by COVID, and therefore through that exacerbation, it makes it even more challenging then for us to really think about what needs to be done for HIV prevention in the context of this post first phase of the pandemic. And it may mean that greater care needs to be taken in addressing and responding to some of the social and economic realities that people now face themselves in. And then finally, COVID really exposed vulnerabilities at the systems level, and whether it is how services are being delivered. In many cases, it's through innovation, much more digitally, but in some cases, in terms of community-based services, they may have been negatively impacted by COVID. And we will have to think about resources which are available for prevention, what type of prevention is necessary at this stage, and new models of care and prevention in this new phase as we emerge from this first phase of the pandemic. So colleagues, my final slide then is just to conclude. It's been an important piece of work which has subsequently spurred on not only action across government, but action in local government. And I know that many of you have looked at the recommendations and are implementing it in your own organizations and institutions. This is an unprecedented pandemic, and it's an unprecedented time. And if I've learned three things over the past, well, I've learned many things, but certainly over the past 6 months. Number one is that partnerships are essential, because it really has helped us, certainly in London, to get to where we are in this phase of the epidemic. Second, it's important that we share a vision for not only ending the COVID pandemic, but a vision for what life after COVID will look like as we recover. And that vision has to be shared across partners, because it will require us to work in new ways and to continue to build upon the things that we have done. And then finally, what I have learned and what we continue to see as we see COVID emerging in different parts of the country is that we cannot control this epidemic without engaging and having strong community infrastructure, which has meaningful, appropriate, and acceptable interventions to support those communities to respond. So whether it's looking at communities which are deprived, whether we're looking at migrant workers from Eastern Europe, whether we're looking at gypsies and travelers, or whether we're looking at South Asian populations working in clothing factories. These are all community contextual factors which require working with the community to find solutions that will work for them. And that's going to be a key part of our work moving forward. So Gemma, with that, I'm going to end there. And I hope that we were able to see the slides clearly and hear the presentation clearly as well. Look forward to any comments that colleagues may have.
Yeah, so people might want to come on screen at this point. If we start to see any transmission problems, then we'll turn our cameras off, but people might want to sort of pop up on screen and say hi. The session is still being recorded, so if you don't want to be on it, then please keep your camera off. Kevin, thank you so much. That was really, really clear. And even with the disruption of a squeaky toy and a sort of thrown in and out of the room, you managed that really, really well. And we've had such great attendance today. So we're going to sort of move into the Q&A session. I mean, HIV is a condition that clearly thrives on social injustice and inequality. And so within that context of what Kevin set, I'm sure that you as the HIV community have many fears for what kind of this might mean in terms of the impact of COVID on the work that you do, the populations that have become more at risk as a result of COVID. But also potentially have some hopes in terms of new ways of working, new models, new opportunities around what's been highlighted to us in terms of inequality and what more we can do to address that inequality, given the amount of focus that is being placed in society as a whole. The opportunity to really kind of seize this moment to do more is there. And I think there was a sort of a comment on your report, Kevin, your national report, that this must lead to change. We must have a fairer society. So there's an opportunity now, everybody, to raise any questions that you have. Probably the best way to do this is if you could kind of put your hand up or put a question in the chat box, and really just any thoughts or comments that you have. So what are the kind of, I guess, the hopes and the fears? Bibiana, I think your first hand up. So would you like to put a question to Kevin?
Hello, Kevin and everyone. That was a beautiful presentation. My question is, we know that, and we've heard this from data and many other places, that BME communities are hard to reach and they present late with illnesses. So they go for treatment when they present late with whatever illnesses they have. But from your presentation today, I'm getting a different picture because you did mention that BME communities were more likely to be tested for COVID and likely to test positive. So it's a bit confusing for me because on one hand, we hear that BME communities usually are hard to reach and do not go to get treatment and present late because they don't get diagnosed on time. But here today, we're hearing that it's different. So can you explain why that is the case?
Kevin, you're on mute. Sorry.
I was just thinking, in the interest of time, shall we take a few comments and I can respond to, yeah.
So, Deborah, you've got your hand up as well. Would you like to give a question too?
Hi, Kevin. Thank you very much for that presentation. It was really good. One of the questions I have there, given the fact that you've got the issues with the BAME population and the comorbidities also driving the issues with COVID, we've also got the fact that HIV also exacerbates some of those comorbidities. Now, in the world that we live in and the fragmentation of services, how best can we ensure commissioning for patients living with HIV so that they do get proper annual health checks, because that is not being done standardized across the actual sort of network of people sort of getting their services, because some people are saying that primary care should be delivering that, and some people are saying that secondary care should be delivering that. And where does the accountability lie? And I think that's something that we need to do when we move to STPs and ICSs, and ensure that somebody's going to be accountable for delivering that. So I think that's something that I would really welcome further discussion with you on at some point.
Great, thank you.
Okay, you've got those two questions at the moment, Kevin.
Okay, great. So very quickly, so you are right. There is apparently, it could be seen as a paradox there, but there isn't really a paradox in terms of diagnosis rates. So remember, many more BME individuals were more likely to be exposed to the virus, in part because of the jobs that they had, whether it's key worker positions, caring professions, etc. And so in this first phase of the pandemic, what you saw were these high diagnosis rates because people were becoming unwell. But what the qualitative data showed, and what we heard from stakeholders, was that even although people were testing, the journey of going into the hospital and being tested often took a long time for members of the BME community, in part because sometimes they were afraid of being diagnosed with COVID. Second, they were afraid of going into the hospital and maybe acquiring COVID. And third, historical poor relationships with the healthcare system may have also prevented people from actually going in. But once they went in to get tested, they were more likely to be diagnosed with COVID, which is why you see the data that you've seen. So hopefully that explains that. So a higher level of community transmission meant that your likelihood of being diagnosed was higher, but that journey to the hospital was more difficult for BME communities. And in some instances, we see this in terms of the level of severity that BME individuals presented with the hospital with. So they were more likely to actually pitch up at the A&E department with severe disease and then move straight into ICU because they had delayed access to care. So one of the key recommendations is not only get tested, but get tested early and seek care earlier within the course of the disease. And then the second question on fragmentation, I couldn't agree with you more. And I think this is a really good time for us as we rebuild and restore services to think about how we do things differently. And I know the HIV community has adopted and adapted digital ways of engaging and doing remote consultations, but we need to do more than that. And I think the time is now right for us to think about what does a new model for HIV care look like, which aligns more with the models for non-communicable diseases or chronic diseases, but also builds upon the best aspects of HIV care, which includes that whole person care that many of the NCDs don't have. So I think now is the time to have the conversations as we restore and as we redevelop services and not allow this opportunity to pass.
Thank you, Kevin. I'm sort of struck by the opportunity on inequalities at the moment in HIV. In London, we have a high number of inclusion groups in hotels at the moment. So you'll have, perhaps people have attended the previous webinar on the homeless, and I was leading the homeless incident as a COVID director for that. And, you know, but there are many hotels with modern day slaves in them, people who are in domestic violence situations and they're using them as safe houses, people coming out of prison on probation. So a huge number of our inclusion groups at the moment are in these settings, and there's a real opportunity there for those who attended that webinar to do more and address the inequalities for them. And certainly people have been working with the FTCI to try and kind of address that challenge, and we're finding undiagnosed cases. So that's been a really kind of positive piece of joint partnership working, looking at particular inclusion groups. I've got somebody with their hand up now. I'm going to struggle with your name. I'm sorry. Is it Isaacon?
Yes. Thanks,
Hi.
Kevin. Hi there. Thanks, Kevin. Very informative presentation. Just a quick question regarding how the data were collected for ethnicity. So in terms of when we're looking at, you've kind of presented on the data in terms of ethnicity in Britain, but if we compare it to the data collected in where BME are mostly like in Africa, we can see different trends. So could you explain why is the rationale? Because here we can see increased risk, but if we compare it, I know obviously with other countries like Africa, their rates of underreported cases. But however, if we compare the testing rate and the diagnosis, is still lower compared to the UK. And also, is there a reason why the difference is? What's the rationale on that? And just about the way the data is collected, I mean, are we looking at the BME population as a whole? Because if we look at it in that mode, compared to the UK population in UK, looking at the BM population profile compared to non-ethnic, it's higher, so that will affect the risk. So I just want to understand the rationale in terms of how it was collected.
Okay, we've got one other question from Nuala, and then we're probably reaching our time at the end. So if people have to leave at 5, then please do. But Nuala, do you want to just ask your question of Kevin as well?
Hi, yes, good afternoon. Speaking very much as a lay person, Kevin, our concern is very much on how and if data is being collected specifically on the Latin American community in the UK, bearing in mind its own ethnicity and that it represents 19 countries, the huge language barriers that exist, and the fact that as an asylum seeker, refugee background community, it very often is having its main employment in, for example, the cleaning industry. And the majority of people that we know, their information was very limited. And many people were carrying on with cleaning jobs and so on, because these are people working in very difficult circumstances and at high risk. And we believe that from the people that we know face to face personally, that the impact is very, very high on the Latin American community. And this is not being collected. What I understand, again, as very much a lay person, my understanding is that during the quality research on HIV, that the Latin American community was recognized as its own ethnicity. And this revealed that the Latin American community was seeing a rise in HIV. And we believe, especially in the Latin American network, I'm here as Carnaval de Pueblo and the Latin American network in Southwark, we believe that if this approach to data collecting took place, it would reveal a very different story for the Latin American community, which is hidden. And we would very much like to participate, if in any way we can, at the level of quality in terms of if there's specific funding that could be available, where we can actually help with this, because we are the people face to face with the Latin Americans, and obviously with the language and the friendship.
Okay, Nuala, thank you. Thank you for raising the voice for the Latin American communities. We've reached 5 o'clock, so if people do need to go, that's absolutely fine. But if you want to hear Kevin's response to those 2 questions, those 2 final questions, then do stay. Kevin, over to you.
Okay, thank you. So to the first questioner, we do see significant geographic variations. And I think that we're in such an early phase of the pandemic and really understanding how it's spread and who's at risk, that studies such as international comparisons are going to be really important to understand why some communities have a disproportionate burden in different settings. Clearly in the United Kingdom, where many Black, Asian, and minority ethnic communities are, and what they experience in terms of social and economic and structural disadvantage may not be the same in their countries of origin. And therefore, some of those factors would certainly influence the differences that you see. Some people have postulated that in the warmer climates and more exposure to the sun, that vitamin D might be an example, a reason. I think the data are not yet available to confirm that, and that needs further research. And of course, we have to think about the ways in which the epidemic was introduced into different countries and how it gets seeded and spread. And you mentioned Africa, but there are so many different stories in Africa, and we see the tremendous epidemic occurring in South Africa, the Republic of South Africa at the moment, where they're seeing skyrocketing rates, which are rivaling both the United States and Brazil. So again, looking at different countries and different settings will be important. The ethnicity data that we collect does unpack a variety of ethnic groups, but I do take Noala's point about the Latin community and the ways in which we need to unpack the data for the Latin community. But I have been working both with the testing system and the contact tracing system to ensure that we collect much more robust ethnicity data. And finally, you will begin to see more of those data now being published, and for us to really have a look at how the infection is being concentrated in different groups. But again, Noala, I think we will need to do further work on the Latin community, because it's often Latins are either associated to other or to white other or to Black other groups, depending on their racial background. And unpacking that requires a special way of looking at the data and collecting the data. So very keen to do that work. And this is exactly an area where we can learn from HIV and HIV surveillance for COVID, which is what I'm keen to do. So thanks so much for the questions. They were fantastic questions as well, and also in the chat too.
Yeah, fantastic. So obviously the challenge of getting to zero is really now about focusing in on those most disproportionately affected by inequalities. And so it's been really useful to use this moment of COVID and these findings and the highlights in this report to really think about how do we all move forwards in our getting to zero aim, and do it in a way that really takes that disproportionate focus on groups, perhaps in a way that we haven't previously been able to. So my challenge to all of you who've been here today, and thank you for staying and for listening for so long to what has been just a fascinating report, is that you go away and you take the messages that Kevin has set out for us with you, continue to build on the great partnership that we've seen through COVID, the great innovation we've seen in the way you've delivered your services, and really just think about the learning and the lessons from these reports and what they mean for how we might deliver our services in the future. So thank you very much to Kevin. Thank you to the Healthy London Partnership team who are behind the scenes pressing various buttons and doing different things to get this to work. And thank you to all of you for coming and being part of this community of learning together. Thank you so much.
Great. Thanks, everyone. Bye-bye.
Thank you.